Stacy Hopgood Wilkes, Steve Horn, Letitia Jackson, Trey Lamar, Fred Shanks, Albert Butler, Andy Berry,
He's here.
Angela Burks Hill, she'll be here in just a second. Kathy Chisholm, Chris Johnson, Rita Parks, Joseph Seymour,
Present.
Sarita Simmons, and Joseph Thomas.
Yeah.
Fred's here. He said he's,
We have to have 9, is that right?
Fred's here. Fred Shanks.
Fred Shanks, okay.
That's my choice.
Mr. Chairman, we have a forum.
Okay. All right, thank you. Like I say, we're glad everyone's here today. We're gonna ask some questions.
Yes, ma'am.
I've got several questions up here, but I think, I'm gonna let someone else start it off. Would you like to start off with the questions?
Well, I think before, Mr. Chairman, before we start with the questions, we would like for
Get on your mics.
we'd like for cities to just give us an introduction and your title, and we want to welcome you to your new position. Okay.
You turn on the switches at the very top. Yep.
There we go. So, can you hear me now? Can you hear me? Can you hear me now?
Here's your try
Hey,
again. Try
good
again.
afternoon.
Try now.
Good afternoon.
Is it all the way up? The switch up? Here you go. Use this one. This one. Check, check. That one's better.
Now we know it's working.
Thank you. Good afternoon, Chairman, and committee members. We appreciate this opportunity to come before y'all today and answer any questions that you may have about Medicaid. I am Cindy Bradshaw, and I was appointed in November to be the executive director to replace Drew Snyder. I also have with me Jennifer Wentworth. She's my chief of staff and previously the chief financial officer for the Division of Medicaid. Just by way of background, I was in the private sector in health insurance for about 15 years, went to work with the Department of Finance and Administration and served as a state insurance administrator. I oversaw the state and school employees health insurance plan, workers' comp, tort claims, and state property insurance until June of 23, when Drew asked me to come over and handle the unwinding process with eligibility, and then here I am today. So I did want to just provide just a little bit of information just by way of background. Medicaid was enacted in 1969 by the Mississippi legislature. So we, each state runs their own program within the guidelines of the federal government. So we have a federal medical assistance percentage, which we refer to as the FMAP. This is calculated every year to show how much federal dollars we'll receive in terms of our state. We're currently at 76.9% that we receive in federal funds. That is reviewed annually and has a possibility of being decreased in the coming years. And so just to kind of give you an idea about what that is, if it drops 1%, that's about $83 million for a year for Medicaid's budget that we would have to come up with. We currently have a budget of $8.1 billion with direct state support of $912 million. So Medicaid provides health coverage for low-income populations in Mississippi. This population includes children, low-income families, pregnant women, and the aged and disabled. We currently have about 707,000 participants on our plan. That includes a little over 107,000 of SSI recipients. We have about 14,000 members in long-term care. We cover 23,000 pregnant women, 315,000 in children, and roughly 10,000 children who were in foster care or on CPS custody. You ask in your letter for us just to provide a list of the vendors that we have, and I've included that in the handout. We have 3 main contractors. Gainwell Technology serves as our fiscal agent. They process our fee-for-service claims, handle provider enrollment. We have a single pharmacy benefit administrator now that they run, and our third-party recovery efforts, and also provide our data warehouse where we can pull reports from our claims and population. We also have a vendor that's named Conduit. They oversee our eligibility enrollment system. And then we have another major vendor, which is Telegen, and they're our utilization management and quality improvement organization for our fee-for-service population. We have 3 managed care organizations, and I've included those in the package. Currently, we have Magnolia, Molina, and United Healthcare. We are in the process of implementing some new MCO contracts that should take effect July 1. And part of that procurement, United Healthcare, will terminate 6/30, and the new vendor is TrueCare. Another item that you asked about was a process for filing reimbursement claims for hospitals and medical clinics. So there's 3 ways that providers can file claims. One is through a portal. They can key the information into the portal that we have on MESA or with the MCO vendors. The most common method of filing claims is to do what we call an EDI transaction. It's an electronic transaction, and that uses a standard national format in a data file transaction that goes over to the vendors. That's the most accurate and the most efficient way to get claims processed. They can also submit paper copies. There's 3 standard forms. There's a UB04 form that's a national form that's used by hospitals to submit claims. There's a standard form from CMS. It's a 1500 form. That is what physicians and therapists and individual providers use to file claims. And then we also have a standard dental form. Another item that you asked about was how we update and our Medicaid patients. And so we do have a website that's available, just the DOM website for Medicaid, that has pretty much all the information that we have. It has our contracts with the MCOs. It has our fee schedules. It has eligibility information. Just about anything you want to know is available on our website. I mean, our goal is to be as transparent with information as we possibly can, and to have any information that the public would need available on our website. We also have a member portal by Gainwell, and also we share an eligibility portal with the Department of Human Services so that applicants can go in one place and apply for Medicaid or SNAP or TANF, and which one they are indicated, it comes over to the respective agency. We also have websites available for the providers. Gainwell has a provider portal where providers can go and they can check eligibility, they can check claim status, they can also see if a prior authorization has been approved, so that all that information is available for them. Our most common method of communicating with providers is a method in which we call our late breaking news. It's an article that we release. We will immediately publish that on our website. And additionally, we send an email to any providers that have registered, and they get a notification via email to let them know that there's a new article that's on the website. We also have our our provider manual that's available there, and anytime we make updates, providers that are in the Medicaid system would be notified that there's an update. That's about all the information I think that you had asked for. If there's other specific questions, I'll be glad to answer those.
Thank you very much.
Can you hear me okay?
Can you hear me? Okay. We have some questions from various people on the committee. I have some, and let me just start off with a couple that I have. You were talking about updating the area where you can see, the providers can see on the portal who is in which MCO.
Yes, sir.
How often is that updated?
It's updated daily.
Well, there's been a lot of problems with people looking at that website and then filing forms and then getting a rejection saying that those folks are not on the web, are not on that insurance. So is there any way we can update it a little more regularly? Or, I mean, if it's daily, I mean, I don't know how you could do any better than that, but they're getting on there and they're saying like, it says Magnolia, and they file the forms on Magnolia, and Magnolia says they're not ours.
So our eligibility system feeds over to Gainwell every night, and those transactions are available, on their website almost immediately if there's some change. What we may not have control over is what's available on the vendor's website, because they also have portals where providers could log into to check eligibility. And so we have experienced some issues with one of the vendors that had some incorrect information. They were not processing terminations timely. And so that is something that we're working through with them currently.
Okay. We also have people who come in and they say, well, I'm with Molina. And they look on the website and they look and they see it says Molina there, but when they file the claims, it gets rejected and say that they're not.
And I'd need to look at those individual examples and try to figure out what was happening with
Well, I was just wondering too, I think it's every year y'all maybe reassign people or divide people up for the MCOs. Is that right? And is there any way that you could have a different number for an individual once they change? I mean, maybe just putting one other character in there that would designate them to Molina or Magnolia or United or this True Blue that's going to come online.
Yeah, we could certainly look at that.
Okay, well, I think that would help because there's a lot of people out there, I understand, they don't know when they're switched. They may be getting letters, but you know how a lot of letters are, they're just chunked in the trash. But they don't understand who they're with, and so that fouls up the filing at the clinics and the hospitals.
So the source of truth should be the Gainwell website, and that's what we encourage providers. And I think industry practice, most providers do check eligibility before they file, because members often don't have current ID cards. So that is what we encourage providers to do, is to check eligibility on the date of service.
Gainwell?
On Gainwell, yes, sir.
Okay, I'll make sure of that, and I'll stop at that and let someone else ask some questions. Okay.
Tell them who you are.
So we currently have presumptive eligibility at the hospital level. So hospitals can apply to be a presumptive eligibility provider. We conduct training for them to give them the basics of eligibility determinations. And we execute an agreement with them that, they will provide coverage. And so they actually submit to us a form that says they've determined that a member is eligible based on the limited information that they have. We also require that they go ahead and complete a formal application and submit that to us so that we can actually make an accurate determination.
How long is presumptive?
Well, it's no more than 60 days. Typically, it ends at the end of the month following the month in which they were deemed eligible.
When the hospital does this, say it doesn't qualify, is there any way to get the money back? Or is this
No, sir. No, sir. We're not allowed to take the money back.
last thing, being that the house cuts to Medicaid on the federal level going to affect ours?
I wish I had an answer for that. I don't think those decisions have been determined yet. My understanding from reading the budget bill was that they were to look for $800 million worth of cuts, $800 billion worth of cuts, and that they were supposed to come back and they'll actually have to get most of the laws changed in order to do that.
And if we was to expand Medicaid, our part of the coast, the cost would exponentially go up also, right?
If any cuts are made at the federal level, the state share is going to go up.
Thank you.
Okay. State your name.
My name's Dan Eubanks. I represent DeSoto County, and I serve in the House. Thank you for being here. I know you've only been at your post a short while, so some of these questions you may have to get back to us on, I know. You were saying something. I actually have a couple questions, and I'll just ask one of them and pass it around. If there's still time left, I'll ask some of the follow-up questions. But you said something that piqued my interest. You said that for every 1% of a cut we get at the federal level, it costs us $83 million. Is that correct? Okay. I would assume that an increase in enrollment of 1% would cost at least that much or more. Would it not? Or is...
That's not an apples to apples comparison.
Well, we had a bill that came through the House earlier this session. It was House Bill 1148, which was the Medicaid tech bill. And in that bill, we took the eligibility qualifications, percent of poverty level, and increased all of them. So if we increased the size of the population that has access or would qualify for Medicaid, correct?
So in reference to our tech bill, there were some changes at the federal level and that we've had to already implement. So the changes in the tech bill are already in practice today.
Okay, so that was just getting it up to speed with what you're already doing.
Yes, sir.
Okay, all right, good. That was just something that came up when I heard you talking. I wanted to ask you about the fact that Mississippi has not expanded Medicaid to able-bodied adults, but enrollment in Medicaid has been expanding. How much has Medicaid enrollment increased, would you say, over the last 5 years? And what do you see as driving that increase? Is it moms? Is it children? Postpartum coverage? Able-bodied adults? Do you have an idea of the breakdown and the increases?
Yeah, so the last 5 years, we started at a little over maybe 730,000 prior to COVID. During the public health emergency, we were not allowed to disenroll anyone that was no longer eligible. So our enrolls went up to about 904,000. So then when the emergency ended, we had a year to recertify all of those beneficiaries. Enrollment came back down. We're at 707,000.
So 707 or 70?
707.
Okay. All right. The Biden administration has made it difficult for states to check the eligibility of illegal aliens for state Medicaid programs. Can you walk me through the current process that we use to verify citizenship or other data points that generally substitute for citizenship in order to get Medicaid?
I'll need to get back with you on that.
I'll share.
You say she have to get back?
She'll get back to us with that.
Okay. Okay, Jamie.
Thank you, Mr. Chair, Vice Chair, Mr. Chair. Thank you so much for being here. I am, like my colleague, Senator Seymour, new to this area as well. I represent District 110, Moss Point, and Pascagoula, Representative Jeremy Anderson. I have a couple of questions, mostly around independent pharmacies. First off, I appreciate the work that the division do in my area. It plays a significant role in the health and well-being of the constituents of District 110. A couple questions that a couple independent pharmacies had, mostly around service access. It is my understanding that the division does not reimburse pharmacies for cognitive tests such as screenings for flu or strep. At one point, I think it was providing reimbursements for COVID during the height of the pandemic, but I don't know if that still exists or not, but does the division offer reimbursements for flu or strep or any preventive screenings?
Not that I'm aware of.
Possibly that's something. that the department could look into.
It is.
Thank you. A couple more questions, Mr. Chair. With inflation, would it be physically responsible to pay pharmacies $1 or $2 more? Of course, we know with the Trump administration's irresponsibility in financial management, we know that those dollars could possibly be reduced. With that being said, my pharmacies, independent pharmacies, are very happy with the reimbursements right now. But of course, with inflation becoming more relevant and more real, would it be possible to possibly look at an increase in pay?
It's certainly possible to look at that. I think Medicaid, in terms of the dispensing fee, is probably the highest reimbursement in the market right now, substantially higher than any private payers.
Thank you, Mr. Chair. That's all I have. Thank you.
Senator Chisholm, if you got something.
This one's different.
We should do it.
Yes, thank you. Is it on? Can you hear?
Tell who you are now.
I'm Senator Kathy Chisholm from District 3, North Mississippi. Thank you guys for being here today. We appreciate it. My first question is, how much has Medicaid spending, both state and federal, increased over the last 5 years?
I may let Jennifer answer that. Do you know off the top of your
In
head?
the last 5 years, we were somewhere around $6 billion. And looking at, and for 25, we're looking at somewhere 8.1 billion.
1 billion?
Yeah. Much of that spending is in directed payments to, they go directly to providers.
So you're saying it has increased, and you're looking for it to increase to 7 billion for year 25, is that right?
25 is 8.1.
Okay. All right, and I only have one more question. How much do you anticipate Medicaid spending to increase over the next 5 years?
Well, let me take a look. I guess it depends. So if things change at the federal level, it will change drastically. Originally, we expected somewhere around 9.9 billion, but I would anticipate that that is not going to be a good figure at this point.
Okay, thank you.
So just kind of as a follow-up to the spending increase, and so in the last few years, hospitals were given supplemental payments, and that was something under the governor's leadership, that it's been roughly $1 billion more that has been provided directly to hospitals, and that's aside from any services that they provide. So, at one time, I think Medicaid was probably the lowest payer for hospitals, and I think most hospitals would tell you now that we're the highest payer. They get more money from Medicaid than they do from private insurance companies at this point due to the supplemental payments. And so how long that will continue, we're not sure. That is something that at the federal level they are looking at.
Okay, thank
Cutting
you.
back.
Thank you. Do you have any questions that you want to ask? Oh, okay. Senator Hill, I understand you have some questions.
Okay, one question I would ask is, in the Medicaid technical bill, I believe it was, we discontinued one of the medicines that was a preterm labor drug. We discontinued paying for that drug, and I was wondering if there was any rationale or reason. Is that drug just not used anymore, or if it's not something you know offhand, can you get an answer as to why that was removed in the Medicaid technical bill, a preterm labor drug?
Was it the P17?
I think so,
Makina?
yes.
FDA's not covering that medication anymore.
So did FDA, they don't recommend it anymore? Is that what you're saying?
Correct.
So they basically have something better now rather than that?
I don't know that there's anything better. I just think that they found that not to be safe and effective as what they did at one time.
Okay, all right. Another question, on presumptive eligibility, I have a couple questions on that. On House Bill 662 that addresses presumptive eligibility, it looks like it removes the current requirements in state law that would require verification of pregnancy, income, on lines 50 through 52. So the presumptive eligibility now, you do not have to prove you're pregnant anymore, is that correct?
You're not allowed to ask for verification based on the federal law. So the changes to the presumptive eligibility at the state level were to make it compliant with the federal guidelines so that we could get CMS to approve the change.
So are you certain that it's federal law, or is it federal rule that's been done by the APA, or is it just a CMS guideline? Do you know?
Yeah, it's in their CFR.
It's in their CFR? Okay, so I guess another question I would have is, and this may sound crazy, but in today's time, I feel like I have to ask it, being that you can't ask or for a pregnancy check, is it possible that that a man identifying as a woman could get presumptive eligibility if you can't ask for pregnancy?
That could be the case. So we designed the program. We had some flexibility with the providers that were allowed to do presumptive eligibility, and so we structured it such that only OBGYNs and primary care physicians would be the ones that could do the presumptive eligibility. In addition to the health department, they could. So we would be relying on the providers to make that determination.
So I guess if you got a federal policy that doesn't allow you to even verify pregnancy, and we got to the point to where, men are saying they're pregnant, would it be in the best interest of Mississippi to decrease fraud and abuse to somehow challenge the legitimacy of a policy like this in court rather than just go along with it?
So, the providers have some obligation in this because they're the ones that are making the determination. And so our approach to this so that we could get it approved through CMS was to put that burden on the providers to make those determinations. They're going to be face-to-face with the patient, and we would assume that they have done a pregnancy test and to confirm that the patient's pregnant before they do the presumptive eligibility.
Okay, so instead of income or pregnancy tests, we're just going to leave it to the provider to decide if they ought to be on Medicaid or not. So what if we have one of those providers that goes along with, the men saying they're pregnant? I mean, I see it every day, and and this state is not exempt from it, unfortunately, and if this is supposed to be for women and children, I've got a real problem where they can't even find out if they're pregnant off the bat.
We share those concerns.
Okay. Now, on another one, this is on transitional Medicaid, and I'm going to tell you, I don't truly understand this, and that's why I'm asking these questions, because I truly don't understand it. So if somebody is no longer eligible for Medicaid, can you walk me through what happens as far as the transitional Medicaid? Like, how long do they stay on it? Does it cover a woman that's had a baby, and for how long? That type of question on transitional Medicaid, because I don't understand the difference, to be honest with you.
I don't know that we have a category that just says transitional Medicaid. I mean, either you're eligible or you're not. So for women who are pregnant, the previous year we extended, they were given 2 months of postpartum care. Now they're given 12 months of automatic coverage. And in the beneficiaries have an obligation to let us know if anything in their circumstances changes that may affect their eligibility, if they were to get married or have an increase in their income. So for adults that may be on Medicaid, once that change is made and we're notified of that change, we can terminate them at the end of the month. For children, once children have been given coverage, they have 12 months of guaranteed coverage.
Okay, and so the postpartum coverage, that is a set 12 months, correct?
Yes, ma'am.
And so there's basically not anything traditional, or transitional. So after the 12 months, you would actually have them show proof of income if they tried to extend their Medicaid.
Yes,
is that
ma'am.
Correct? Unless they were pregnant again by 12 months.
Yes.
And then if they were pregnant again, they'd just go on, correctly?
Ma'am.
Is
Yes,
that
ma'am.
correct?
We're required to do a recertification every 12
Okay.
months.
Okay, I think that might be all. Thank you.
I'd like to recognize.
Well, I do have one more. And this is said and done, and there's probably nothing you can do about it unless we have another occurrence of something like COVID. But during COVID, I had a constituent who got a job and had insurance provided for his children and did not recertify his kids for Medicaid or CHIPS. Well, because of COVID, they were recertified anyway. And he didn't sign anything to keep his kids on the government insurance, but somehow during that year, or right after that year, I can't remember the timeline, he kept telling them he didn't need it, that his kids had insurance, but basically, because he was signed up without his consent, they wanted him to pay back the $2,500 MCO fee on each kid. And we went through a hearing with Cody Smith and with those two parents on the phone. I went through the hearing with them. And basically, Medicaid never did say that they didn't have to pay that MCO fee, even though he didn't sign a paper and he was automatically signed up for Medicaid for CHIPS for his kids. So whatever the federal government does as far as forcing us to keep somebody on the program, just like what I'm talking about with no pregnancy test or no income. That's what happened is they came back and tried to recoup that money from somebody that didn't use the CHIPS because they had put their kids on private insurance. So that's just more of a factual scenario that I wanted to share with you that hopefully won't play out again, because I thought surely when they presented everything on the phone here and that I'll be honest with you, I just told them don't pay it. I said, see if they garnish, see if they take you to court, don't pay it. I don't think you owe it, don't pay it. That's $5,000. Who can afford that? Especially when they're doing better and got their kids on their private insurance. So I just wanted to throw that out there and let you know that did take place, and that was prior to you sitting in that chair. So, thank you.
Thank you, Senator Hill. Representative Wilkes, have you got some questions? Okay.
Thank you. I just have a few questions. So earlier you mentioned, I think you said there was a 60-day window that was covered to determine eligibility. Is that correct? Is that?
Presumptive
Yes,
eligibility.
presumptive.
They're covered in the bill that passed last year. It gave women 60 days worth of coverage, no more than 60 days.
Okay, so
The federal law requires that we terminate them at the end of the following month and the month after the month in which they're covered. So I think that was a change that was made this year.
Okay, that was my question. What happened outside if it wasn't determined by then? The other thing I wanted to ask you was, can you tell me, I know talking about prescription drugs, Medicaid switched to NADAC in 2017 and saved, I think, $55 million. What is the savings each year since then? Do y'all have that?
I don't have that.
Can you get that for me?
Yes, ma'am.
Thank you. And the other question that I do have is, do you know how much y'all paid to manage care 5 years ago versus how much you pay today?
Yeah, we need to get back with that.
Okay, thank you.
All right, I'd like to recognize Senator Butler.
I have one more.
Oh,
Did you have a
I do have one more, if you'll indulge me with one more. There was a lot of stuff added in the Medicaid tech bill on the Senate side, a lot of new coverage added in the Medicaid tech bill. Was any of that stuff, or maybe what of that stuff was requested by Medicaid? Was there, do you recall if what Medicaid had requested in that tech bill as far as new coverage?
The things that we requested were items that needed to get us in line with what the federal government requires.
Okay, but you don't remember the specifics of that?
I mean, a lot of it was changing the federal poverty level percentages to be in line with the new percentages.
Okay. So, but all the new stuff that they were adding or changing, that wasn't from y'all. And so, like, I was told during the tech debate that some amount was calculated by somebody that would show how much more it would cost, which to me it sounded like it was nowhere close to what it actually would be. But so that did not come from Medicaid, an average cost of what all that new stuff, or that did come from Medicaid?
Our
Okay.
actuaries.
Oh, so your actuary
actuaries
did
did that.
actually get that number? Okay.
Most of the items did not have costs.
Okay. Yeah, I knew some of them didn't, but there was quite a few I saw that did have. But thank you.
Ms. Bryce, I guess one of the questions I have, has any plans been put in place to better serve those individuals under the Medicaid plan?
So one of my primary focuses as Medicaid director is to try to break down any barriers to service, to make it easier to do business with Medicaid and easier for not only our beneficiaries, but easier for our providers. And so, health insurance is complicated, private insurance is complicated, state health plan is complicated. And so, I have challenged all of my program areas to look at what they're doing, how they do it, to make sure that it's necessary. Are we still doing it? Does it make sense? Is there a easier way to do that? And just to make sure that we're as effective and as easy to deal with as possible. So.
Okay. Have any plans been put in place to maybe have workshops or conference with rural hospitals or hospitals so that they would be more aware of what to expect from you all, and then a length of time that they can expect? See, one of the things that we find that a lot of our hospitals are facing is that even in turning bills, the length of time that they have to wait creates a problem. And
The length of time they wait for
to hear from you all, and then come back to individuals, and they're saying that individuals has to pay back because they didn't qualify.
Yeah, I'm not aware of circumstances with that, but we do meet regularly with the hospitals. Anything we do with like the payment reimbursement, we have regular meetings, video conferences with the hospitals, and we are looking to partner with the rural hospitals soon to get some of their some input from them on what their challenges are, to see if there's ways that we can help the rural hospitals more.
Okay. Thank you.
Let's go back. Jeremy, Representative.
Thank you, Mr. Chair. I have a relatively large hospital that sits in the heart of my district. Also, again, had very good things to say about the division. They wanted to know about the Mississippi Hospital Access Program, since it's been very helpful as a safety net within the hospital system. What are the plans to maintain and or maximize that program?
So when I took this role, I met with the governor and with the speaker and the lieutenant governor and asked this question: do you want us to max out federal monies if at all possible? And they said yes. And so that is something that we're working on, not only for hospitals, but even for other agencies. And so there's very little room in Medicaid for us to trim up. I mean, we operate on less than 3% administrative cost, and the majority of the money that comes to Medicaid goes to the hospitals out through payments. And so in an effort to try to help this state as a whole, we are partnering with sister agencies to determine if they have services that could be paid for through Medicaid dollars, and we are working with the school systems on the services they provide in the schools to be able to try to push those through Medicaid. We're working with Commissioner Sanders on her services that she provides to see how we can pull those through Medicaid to reduce the deficit budgets that she's having. So we're looking, pretty much across the board at the way we do business to see if there's additional ways. And so, kind of the kink right now is with the new administration, because we're kind of all just waiting to see what cuts they may actually make. So.
Representative Wilkes has another question, I believe.
I have a couple more questions. One thing I wanted to follow up on, I had a issue a couple years ago with a constituent, a provider in my district, and it went through a hearing. She even appealed it and everything. And but what the issue was is they submit for approval, and Medicaid approves them, tells them it's covered, and they treat these patients, and then they're paid, and then years later it's clawed back, and Medicaid says, no, we weren't supposed to pay that. So can you and you may not have it now, but can I see the procedures you have for that and anything that's been done to improve that? And, or shorten the time, or what can be done? Because I know this particular person, she treated Medicaid patients 5 days a week, and she treats them 1 day a week and won't be treating them much longer, because that was a large amount of money that came back out of her pocket when she had filed everything, submitted everything, and was told these patients were covered, and then years later have to come back and, reimburse that.
I've had several of those as well.
So, I mean, with CMS and the federal funding, they provide, 76.9% of the funding. And so if we pay for a claim that they deem is not coverable, that we're required to recoup the money. One option, that we could take, instead of we have to provide that money back to CMS, we could just maintain the payment with state dollars. Which would be a little bit expensive, but that is an area that we're really focusing on right now. We have a program integrity department. We are trying to procure some better software for them that can identify fraud and abuse faster and much faster than what we're doing today, so that we can catch those items. And I feel that is a pain point to go back multiple years. I mean, that's something that really does bother me from a service standpoint, and we are working on a couple of different ways to be able to shorten that time period and to do that more effectively. And so,
because we're losing providers, and when they're trying to do the right thing, submitting, the requirements, and you're saying, okay, this is covered, and then it's not, that is a long time to go back. And, as a business owner, when you're, paying bills and doing things, and you're thinking that money, it's just hard to come back and claw that back years later. So I would be interested in you following out with me on that, on things we can do to shorten that time span. The other question that I had, we passed out a bill last year on 340B drug policy, and I'm just curious, I know Medicaid has the tracker or identifiers on them, and I would just like to know, how much of the drugs that Medicaid pays for it are 340B drugs.
we'd have to get that for you.
Ma'am?
We'd have to get that for you.
Okay, thank you.
Senator Hill.
As a follow-up to Senator Wilkes, Representative Wilkes, she might be a senator one day when I force her to do it. Is there a total? Can y'all come up with a total of what y'all have clawed back based on what CMS has told you to claw back, per year for the last few years, on what y'all had approved and paid and then had to claw back from the provider? That would give us an idea of how much we would have to spend out of the state general fund if we tried to cover some of that stuff to try to keep some of these providers in the Medicaid network. That would help us. And the other thing is, and you probably don't know this right offhand, but being that they've discontinued this P17 preterm labor drug, I'm interested in what Medicaid and CMS is approving for preterm labor, as far as what would take the place or what else is working for preterm labor besides this P17.
Okay, I'd like to ask the committee, we've got a representative here that's been at just about every one of our meetings. He's a nurse. He's up on this subject, so y'all mind if he asks the question, if anybody objects? Okay, Ricky.
Thank you, Mr. Chairman. I just have one quick question. I just want to know how much you guys recovered from fraud and abuse from Medicaid and stuff like that. Do you have a total, anything like that?
I don't have a total right now. We recently submitted our report to the legislature that did have some figures in there. It's kind of difficult right now, and I have my legal department looking at that to get us a firm number on exactly how much we've recovered. I think in the report it was a little short of, it was less than $2 million from what our program integrity had recovered last year. A lot of the recoveries, though, happen through legal settlements, which kind of leaves our program integrity area, and then it goes outside for legal counsel. And so I've asked them to give me a list of everything that we have pending and what we have, recovered. I know, just recently, my legal staff told me that there was a situation where we've recovered, I think it's $7.2 million in one scenario, and so I need to get some better numbers on that. that. One of our challenges right now that we have with provider appeals, like if we submit a notice to a provider that we have discovered something that's either falls under fraud and abuse, or either through a lot of our services are reimbursed based on cost reports, and so we do audits on their cost reports, and if we find out that they've added stuff to their cost reports inappropriately, we can go back and adjust what their rates are. So the way that process works currently is we send a notice to the provider telling them that they owe this money back, and then there's an appeal process, and we do an internal appeal with some administrative judges and hearings, and if the outcome's not favorable, then they have the option to go to court, and then that can drag out a long time going through. We've got a case now that's been going on for 7 years, 8 years. It's at the Supreme Court, and so there's not a lot of incentive on the provider side to push that litigation along if they owe us $12 million. And so we'd like to switch that, where if the state deems that you owe this money back, we take the money back immediately, and then they have to go through the administrative process to prove that we took it back inappropriately. That will put the incentive on them to be more proactive in getting the litigation through.
And the follow-up is, how many investigators do you have to follow up on fraud and abuse?
In that department, we have, I think, about 25 employees.
Okay.
Thank you.
Thank you. I've got a couple other questions. Is there any way we could set a time limit on how long the clawback can go to? I know recently there's a clinic I'm familiar with that it's almost 2 years.
Yeah, I don't think with CMS that there is a time limit.
Okay. Would it be with the MCOs? I think the MCOs are the ones that's asking for it back.
In that, the majority of our members are with MCOs, so that's probably going to be the case. But to have a hard timeline on that, would be a bit of a challenge because of the CMS requirements to.
Well, I was just thinking, there's always a hard requirement for them to get it in. So, and if they go through it and pay it, it looks like they've looked at it pretty good. So, anyway, let's see. Before we started MCOs, we had, I think somebody told me better than 1,000 employees at Medicaid. How many employees do we have now?
We have less than 1,000.
Less than 1,000? Do you know if there was any cuts after the MCOs picked up what they were supposed to pick up? They were supposed to do some of the work for y'all.
I'm not sure.
Okay, I know that was before you came. Do you know if the MCOs have hired extra people to work to help get these amounts that are coming back to them from the providers to get them certified and paid, or if they've done anything to help the process get along?
I don't know. I really don't know. And so, one of the things that I do is, like, anytime there's an appeal, I personally review the outcome of that appeal and to make sure that I feel like it's done fairly. And so we're looking at that. I also look at the recovery letters that we're sending out asking for the money back. And so all of those I'm using as a QI opportunity to try to figure out what could we have done to have prevented this. And that's really my focus, is to make sure not that we're not recovering monies faster, that we're paying them correctly the first time. And I think if we can focus our efforts on making sure that we're paying claims timely and accurately, that's going to reduce the biggest part of the recovery.
When you're talking about you and you saying we, are you talking about Medicaid and the MCOs?
Yes, sir.
Okay. All right. Has anybody else got a question?
Thank you. Just a little follow-up to Representative Thompson and the chairman about fraud. I know the Government Accountability Office deems Medicaid to be riddled with a lot of fraud and abuse. if an MCO goes after fraud and abuse and they get money returned back to them, do they give it back to the state, or how does that work? What does that whole process look like?
They do.
They do. What can you describe for this committee what measures you guys are taking to ensure, or either to look into fraud or to ensure that we get it right the first time, that we don't have people that really aren't supposed to be on the program, and that we don't have providers that are, milking the system, so to speak. Are there any specific things that you and your leadership is doing to try and root out fraud or to ensure that's not?
With our eligibility system, and we check various resources, we look to see if they've moved it. We have connection through the Department of Defense to see if they have coverage in any other state or if they live in any other state. We have connectivity with the Employment Security Commission to be able to verify their income limits. So we have multiple resources that we check for information. I think probably the biggest gap is whether someone is married or not and whether they count their spouse's income. And that's something that if they're separated, they're not living in the same household, then they may be married, but if they tell us that they're not living in the same household, then we can't count that income. So I think that's probably where the bulk of the abuse is.
Thank you.
Thank you. Let me ask, is there any other questions? We got them here. And we do thank y'all for answering all our questions. I had one of them, but it slipped my mind, so I'll get that to you later. But we do appreciate y'all coming today. We thanks for the promptness of answering the questions you could, and we're looking forward to get some of these things back that you have to look up. But I want to applaud y'all for coming, and thank you very much. Do I hear a motion to adjourn?
No.
All in favor? Yes, rise and report.